was at 13%, whereas the disease was at 1%. And nearly 25,000 children are born with sickle cell anemia annually in Uganda. 60% die before their 5th birthday. However, to date, these statistics are changing because of support from a number of partners, the majority of them the private sector, that came in to support us when we raised the issue that there is a problem that needs to be addressed. And raising this issue needs collective voices from all of us. When only one country talks, it is not enough. It is important that we all talk, and we all talk with one voice so that people know there is a problem. So to date, out of the total estimated number of about 30,000 children with sickle cell disease, this does not include adults because they are those who have grown up with sickle cell disease. About 4,000 are currently on hydroxyurea with support from various through our 7 centers of excellence that have been created with support from partners. In these centers of excellence, they are offered treatment, they are offered screening, and they are offered daily care. Apart from the 7 centers of excellence, we have 70 satellite clinics that continue to offer care to these patients. We have had a number of research done in Uganda, including the survey. We have had the hydroxyurea trial done in Uganda because we had heard a lot about the trials being done in the US and many other countries, but we specifically wanted to answer the African context. How does it perform in the African children? And we got our answers. We still continue with a number of trials to address the issue of safety and also looking at various doses to support the children. As all of you are aware, if it is not diagnosed early, an intervention started in good time, sickle cell anemia is a very debilitating disease with a broad range of crises that occur in the children, and many of them with very high mortality, especially the acute chest syndrome and also the sequestration. The disease causes untold suffering, not only to the children, but also to the affected families, because the families will never have time to rest. They are affected socially, emotionally, economically, not to mention the stigma that is attached to the disease. And the stigma is very painful to the children, even when they go to school, because fingers are pointed at them. That child has sickle cell anemia. That child is going to die soon. That child will not live to see their next birthday. And that is very traumatizing to the little children. And not only to the little children, but also to the families. We're already aware about the enormous pressure that this exerts on our health systems, some of them already weak and struggling to deal with other disease burdens, and yet also having to deal with sickle cell anemia and the demands on laboratory testing and the health commodities, including hydroxyurea, which we want to appreciate Novartis that has taken great strides in ensuring that the costs of the medicines come down. The medicines have been quite expensive, and many of our countries do not have hydroxyurea listed as essential medicines, because from time immemorial, we have known that it is medicine that is used for treatment of cancer, not treatment of sickle cell anemia. But now that the information is widely available, I want to urge many of you to include it as part of the essential drugs list and encourage our countries to also think about allocating domestic resources to support, because many partners will first look at what is the country doing before they come in. What is the country doing to support, so that whatever support is brought in is additional. Now, I need to talk about what we need to do together. First of all, we need to look at the systems in place. Our countries need to plan. We have been planning for many other disease components. We need to plan for childhood diseases in a holistic way. And sickle cell anemia is one of the non-communicable diseases. So if you're addressing non-communicable diseases in children, and you're looking at diabetes, you're addressing renal diseases, perhaps hypertension in the children as well, please do not forget sickle cell anemia. It is a non-communicable disease, just like the cancers that the children get and many other non-communicable diseases. We need to tailor our health systems in such a way that there is a system flow for these children who are suffering and need to be catered for. Because by the time they report to a health facility, and many of you who may be practitioners know, they come in pain. And they come when they are anemic and they need care urgently. There is need to support diagnostics for newborn screening so that the cases are identified early and initiated on treatment as early as possible. There is need to make hydroxyurea more affordable, not only for a few, because even in Uganda, it is only currently limited to a few. Not everybody will be able to afford it for the rest of their lives because it is taken just like the antiretroviral drugs. It is for life. So it needs to be made more affordable. We will need to intensify public awareness and education campaigns and encourage premarital testing and counseling for couples, especially when they know that this is a genetic disease and both men and women are contributors to this disease. Although in many parts of Africa, people still believe that it is the women who are responsible. So it is our responsibility, me and you, to demystify this and make people know that both contribute to sickle cell anemia. There is need to have appropriate policies, guidelines, both for treatment and care of these children. And this is not limited to only those of us in the room today, but there is need to spread information that if we are to achieve the Sustainable Development Goals on health, we must address sickle cell disease. Therefore, for me today is a landmark in our fight against sickle cell disease, something we started nearly 10 years ago, and I have some calls for action. And one of them is to call upon researchers in this room and out of this room to increase efforts to generate more knowledge, new knowledge. We are all looking at gene therapy, but it is not affordable. Not even the bone marrow transplants. Even those who have managed to do it, we have lost children. So we need more research into more easily affordable technologies, even as we wait for the gene therapy to to become more affordable. Again, we are calling upon pharmaceutical groups to innovate more new drugs, simpler to use, and perhaps much more cheaper. We are proud of hydroxyurea. I know there are a number of other drugs that are undergoing trials, but we should not stop there, knowing that this is a genetic disease. We need more groups to develop simple, accurate, and affordable diagnostic tools. As many of you are aware, there are no rapid diagnostic tests for sickle cell disease. And we have to continue with the protein analysis. And not only that, but there is also need to follow up the children on hydroxyurea on a routine basis. So we need more technologies and more that can be taken closer to the people. We need to encourage our governments, more especially in sub-Saharan Africa, not to group sickle cell disease among the neglected tropical diseases, because it is progressively becoming one of the neglected tropical diseases. Otherwise, we risk losing our children. We need to call upon our health workers to invigorate their passion for care of children with sickle cell anemia. And I want to bring on board political, cultural, religious leaders, opinion leaders, the media, to continue with sensitization about sickle cell disease. Of course, I will not leave out the civil society organizations and the private sector. The civil society to continue with advocacy, and the private sector to continue to offer us support. It will take all of us working together to reduce the burden of sickle cell disease all over the world and alleviate the suffering of the children that we all love. So once again, allow me to appreciate all of you for coming, and it is my sincere honor and pleasure to declare the Worldwide Sickle Cell Coalition officially launched and the opening up of a new chapter in our fight against the sickle cell disease. Thank you very much for coming and for listening to me.
That was a very powerful video to hear a mother find out her son's diagnosis and worry about, lowering potentially of his life expectancy. I think brought probably tears to many of our eyes. But then to hear that same mom conclude on the power of partnerships, it was really a hopeful ending. I just wanted to thank, once again, Minister Acheng and Dr. Hegeman for setting the stage and your passion and commitment in addressing sickle cell disease. And I wanted to now kick off our panel by introducing Spring Gambi, who is a partner at Market Access Africa, and she'll also serve as our moderator of the panel. Spring leads the strategic advisory services to multilateral agencies, governments, and NGOs working towards equal access to health with particular focus on the needs of medically underserved, vulnerable, and neglected populations. Spring.
I'm going to depart from what I plan to do as my introduction to the panel. And I'm going to ask you, Selena, you said we hold hands. Oh, yes. I'm going to sit. It is my privilege to be here with you today. Megan has introduced what I do. Who I am is a woman of Kenyan heritage. We just discovered we come from the same village. Our people have the highest prevalence of malaria and therefore of sickle cell. There has been sickle cell death in my family, as in yours. It is a thing that accompanies everyone who comes from our part of the country. And so I'm glad to be a newly inducted member of the Global Sickle Cell Health Coalition and to introduce Selina Lwando-Gweno, Chairperson of the Children's Sickle Cell Foundation of Kenya. Selina, please. And to invite to join me again as part of the panel, Dr. Lutz Hagemann, President, Global Health and Sustainability at Novartis, and also many of you will know, a long-standing advocate for infectious diseases in the tropics. Please also join us, Cynthia Mwase, Director for Health Africa, Bill and Melinda Gates Foundation. Yes, I think Cynthia is not here, but we shall proceed. And Dr. David Rippon, who is Executive Vice President of Infectious Diseases and the Chief Science Officer at CHAI. And to kick off the discussion, I am told we have live mics, so if you could just each pick one up, and I will start my questions to you, Selina. So when we were talking, and as the video has shown, Selina has now a young man, an 18-year-old, living with sickle cell disease. And as a parent and caregiver, you've highlighted some of the complexity of living with sickle cell disease as a family. What do you want everybody else here to understand beyond what was shown there about the reality for families living with SCD? And if I could beg you to also provide a little bit of the cultural context and explain what it is that we call chira. Thank you, Selina. Is it not live? I think just. Is it already live? You just speak? Okay, just try.
Okay. Oh, great. So she wants me to explain what chira means. Chira is where you do something that is unacceptable, and therefore it's believed that the gods or the spirits curse you. So whenever you get a child who has abnormal behaviors or something that doesn't make sense, or where death is quite prevalent, many a times people associate it that it's chira. You must have done something that makes the God so angry that they want to kill everybody in your life or punish you. That's what it means. Yeah, so getting to your question. As a parent, I believe today I thought I was going to say a lot, but I'm quite impressed. Honorable Achieng Aseng, her name is similar to mine, but now in my country we call it Achieng, and her country, I think it's Aseng. Oh, it's the same. Okay. So Honorable Achieng has described what I thought I was going to say. And when I was listening to her, I was thinking, she's talking about my notes. But again, but that just means that that's how similar sickle cell is. So as a mother, you can see the first thing that shocks you is when you have a child whom you're told your child is not normal, your child is not okay. But the scary part about it is that when it's sickle cell, everything we learned about sickle cell was death. There was nothing about life about sickle cell. And I was fortunate enough to be in a space where I could even afford diagnosis. So at that point, I discovered early. My son was diagnosed when he was 9 months old. Today he's 18. And at that point, nobody was sensitive enough to even come and give you the knowledge that you needed to know. So it was you to find your way out in that scary moment and then look at your child and think, this is where we are headed. My child was very beautiful. He was healthy, looked really nice. So I couldn't see death, and that really disturbed me. I was like, no, he's not going to die. If this is the case that we are going to fight with God, maybe this is one of the challenges. I need to challenge him that let's go into one of those duels so that we see who wins. But again, you can't challenge God. So diagnosis is one of the things that I think most families are struggling to get in my country because it's expensive. You bring a child to the clinic, you tell them we need to confirm that this child has sickle cell. But then the parent, because they can't afford, they'll wait for until when that child is sick and come back again. You cannot send them away, but you have to create continuity of managing this child. So we have had cases where we have very late diagnosis that lead to complications. And when you want to look at it, try and imagine a 5-year-old with a stroke. Today morning I watched a video and I found myself shedding tears, yet I see these kids almost every day. But the saddest thing about these children is that they cannot do anything for themselves. And then you expect the parents to go to work and come back and take care of them. Now the parent in that video represented exactly what we are going through within our facility. Your child is diagnosed late, they develop a complication, and therefore the parent cannot work. But then the bills come, you go to the hospital, you're expected to pay these bills. You're expected to even do more than you're supposed to do. And this is where, in this discussion, we are looking at what priorities do we give to life. If one child had sickle cell, I think all of us should give it priority. We shouldn't say that we are waiting for 20% to call it a national disaster. I think my son is a priority to this world, not only to me. And therefore, diagnosis is done. But then, where do you take this child for treatment or management? Who teaches you? So what happened is when my son was diagnosed, I was fortunate I was still working. And therefore I said, I don't care what happens. I will save money every month and take him to the best doctor. And I'll always take him when he's healthy. So I used to go to our doctor, he was a pediatrician, Dr. Casey Wafula. He's also the patron of the organization. And I would carry him and say, check him and see if he's okay. And he would check him, he would get to teach me a few things. And that's how my son, I can attest today, had his first crisis last month because he's a teenager who was thinking he's now fine. I'm glad he got his first crisis so that he understands that it's important for him to take his medicines. But that constant care has made my child be healthy and not develop complications. And that was the dream now I had for every other parent who has a child with sickle cell. Let's get a facility. Let's negotiate to the lowest so that it's not only the hospital for the people who have, it should also be a hospital for those people who don't have. Novartis have visited us many times. And I remember the first time they wanted to come to a facility, I laughed. I said, this time round, the first world is coming to the, to the whole of the world. We are in the middle of a slum. And it's not just a slum. You know, slums are quite congested, life is hard, and people are so many and everybody is busy. So that is the kind of life that we are also trying to get these people to understand, that living in that slum, you still can access good care. And partnering with the German doctors, which is now the Baraka Medical Center, has changed the lives of very, very many people. Now, these families cannot afford $3. That's the consultation. They come and tell you, I don't have. I'm fortunate that I can afford it, but there are some who can't. And therefore, we have programs where we do subsidies. But all hope is not lost, because I always say that if you work hard to change a system, create a demand, it has put us in a very good place where now people are recognizing the work we are doing. We wanted the government to take care of this, but we realized that in the priority list, we were still so far. So before we get there, how can we get there by ourselves? And this has been run by caregivers and people who are passionate about sickle cell, to make sure that we at least create the demand so that when they come, they find that there's a population that's being taken care of. One of the things that we take care of, which is quite important, is we try to make sure it's zero pain. When the children walk in, sometimes they walk in crying, but we always give them a timing of 1 to 1.5 hours. They'll be playing outside there. So zero pain is one of our mantras. It has to be managed. We are also looking at their safety. I know today the world is talking about child protection and safeguarding. We're also managing the children's safety and also managing how the intake of drugs are being done. We are also taking care of things to do with commitment. When they come, we don't want them to get strangers. When we operate public facilities, today it's this doctor and the next day you'll get another. So we create a consistency where it's familiar faces, and these people then now learn to trust us. And finally, communication is one of the things that we try to ensure that works hard. So yes, it's hard, it's not easy, and you can imagine we are doing it in only one center. We are trying to replicate it in many others, but it's work in progress. Thank you.
Thank you very much, Selina. I have been remiss, and please forgive me. Here with us from the WHO is the country representative of Malawi, Dr. Neema Kimambo. And Dr. Kimambo, you are very kindly stepping in because the WHO regional director for Afro is unable to be with us, in fact, was unable to travel to Europe. And so thank you. I make you sit down, and then I ask you a question right away. And I'm sorry about that, but here we go. You know that the reality that Selina is facing with her family is replicated over and over on the African continent. But, and so maybe I can ask you to reflect on two things. Why do you think there is so much neglect of sickle cell disease on the continent? But what are you hopeful about? The tide is turning, and that real progress is and will continue to be made in management of SCD.
Thank you very much. Excellencies and, is it on?
It's on you to speak.
Excellencies and distinguished guests. It's an honor for me first to represent Dr. Moeti here. I guess people would ask, WHO country representative, how? So I'm a pediatrician. I also worked at the, I've worked many years both in clinical and in public health, and part of my work was at the regional office, even when we were discussing some of these things with, I've been on calls with Dr. Odame. I'm seeing him now physically. So I think that's why I've come as part of the regional team, and I was asked to represent Dr. Moeti. So to answer your question, I think one of the key issues why there's neglect, while we know it's a problem, there is paucity of data. And many countries are working on estimates. I think we saw clearly how the Honorable Minister mentioned that she was now being asked by the President, and they had to do a survey, so they have some more concrete data. And I think it's because of this that it affects the political attention, and also the whole resource mobilization. And then sickle cell falls through the cracks when it comes into policy, into planning, as well as into policy, as well as the whole planning and the attention generally. Then you come to issues like newborn screening, which is very important. We see it's important because patients are able to get care early, but so for diagnosis, for survival, but it's also for surveillance. If you have a good program with high coverage, then that would also help in terms of ensuring that you have data on the prevalence of sickle cell disease, and these are things that are lacking. And then the stigma that all of them have mentioned, that also there is a tendency of not understanding the issue, and because of the stigma, it doesn't also get the attention, sometimes hiding children who have these conditions, and particularly when they have complications. Why there's hope? I would say that, first of all, there has been, at least in recent years, more advocacy around this area. In terms of the African region, in 2006, this led to endorsement of a first regional strategy for sickle cell. And in 2010, when they were now, the advocacy was in 2006, and in 2010, a strategy was developed. And in assessment of this, there was some progress, not huge progress, but some progress. And among that was that now in ministries of health in several countries, they were now putting up units that were specific for sickle cell, and also planning. So we had at least 23 high-burden countries in the African region who now have units within the ministries of health to begin to look at programming for sickle cell. I think another important thing for hope is, the global advocacy and coming together of different stakeholders, as we're seeing, like with the sickle cell disease coalition, where it's bringing together governments, UN organizations, it's bringing together pharmaceuticals, private sector, academia, researchers. So all of these have different roles and pieces to fit in, and I think working together under that coalition also brings a lot of hope, because there are various areas that we can work on together to take this agenda forward. And then the other one, which I think is exciting, is the advancements in the pharmaceutical field, the issues around improving diagnosis, the more modern tests for newborn screening and perinatal diagnosis, though yet they're still limited and more used in the West, but there's hope. The plan is to see how do we get these more to lower income countries. And the other issue also is now in the treatments, the hydroxyurea. There are other, of course, interventions that are always there, the immunization, the prophylaxis, and protection from other diseases. But the hydroxyurea being one, while it's still not available everywhere, but it is a source of hope if we're able to scale this up. And then even more further advances, as we're talking of gene therapy, bone marrow transplant. And having had this, I think once you begin to get improvements in a certain area, it can be dynamic. I think, as the minister said, we need more. We need more affordable. We need to expand. We need researchers. And I think we've had, I think this is one area where even within the African region, we've had very strong researchers in some of these countries that we're seeing here in Uganda, in Ghana, in Tanzania, in Nigeria. So I think to us, I think those are things that bring us hope that there is light. Thank you.
Thanks very much. And as we saw in the film, one of the beacons for hope is Novartis and the sickle cell disease program at Novartis, which consists of various public-private health partnerships between the company and ministries of health, patient groups, non-governmental organizations, etc., to improve outcomes for sickle cell disease patients. So, Dr. Lutz Hegemann, you're back on stage. Could you elaborate for us how you knew that partnerships were so important in the fight in SCD? And also, in talking about future hope, tell us a little bit about the progress that is being made in the newborn screening app that you have now introduced in Africa.
I think if I reflect on what I've heard so far, and that's sort of in 1 hour, the journey that we have been through at Novartis over the last 3 to 5 years, then 2 things stand out for me. One is the tremendous suffering that comes with the disease, and I think no one can explain this in a more touching and credible way than Selina. And the other part is just the complexity of disease management that is necessary. And when you look at the continuum of care, then there is many steps that need to be in place for a comprehensive sickle cell disease management. And that's what we realized when we sort of put our toe into the water in sub-Saharan Africa. And Spreng, I would say we had not realized probably the magnitude of partnerships that was necessary in order to make some successes and to move the needle. But it's very clear to me that as a private sector player, you can see a need, you can make catalytic investments, you can have a will to succeed, you can put your resources behind it, but essentially it's a drop in the bucket if you don't partner with other organizations. And that's what we are extremely open to do, because we feel that that's the requirement for a program to make an impact. And let me just call out a few. When you look at the value chain, then we had to partner, rightfully so, of course, with professional societies, because who are we as a private sector player to work directly on treatment guidelines? So we're very happy to partner with the American Society for Hematology and the local sickle cell disease foundations in order to have national guidelines that were approved by the respective ministries, disseminated, and then implemented. We have heard many times that screening is incredibly important, and I'm very grateful that we could partner with PerkinElmer, and PerkinElmer came on board and said, what can we do? We are a diagnostic powerhouse, and we have one of the most advanced technologies. Let's sit together and let's see where are the barriers and what can we do in order to work alongside Novartis in order to make progress here. And essentially it goes on and on across the entire value chain. But since you had asked specifically also for the data management and the digitization of patient data, we felt that there was a huge opportunity to find ways to keep the data present and to let the data travel essentially with the patient during the patient journey. So we developed together with a digital company a newborn screening app that essentially then can also be assessed by the caregivers later on. We can calculate the adjustment, the weight adjustment that's needed for therapeutics like hydroxyurea for safe and effective use. And it just makes the leap into modern technology rather than trying to expand on paper technology. And very happy to say that in Ghana, we have now 80,000 newborns registered on this app. And thanks to collaboration with ASH, we have just expanded this to another 10,000 patients, and hopefully we'll be able to expand this even further. We have also been partnering with local universities for monitoring and evaluation because we felt that we should tap into local academic networks and let the countries evaluate, the countries' thought leaders evaluate the programs that they are doing rather than have someone parachuted in and out, because we would like to strengthen also the academic ecosystem. And many other areas that we have been actively looking for partners, continue to look for partners, and are very grateful for every organization, whether it's public or private, that shares our vision and brings complementary skills into the coalition.
Thank you. Thanks very much, Lutz. And Dr. Rippon, Chai is maybe one of those new partners to whom a hand will be extended and from whom a hand will be extended in health and partnership. So few global organizations invest in sickle cell disease, but you have recently announced a new sickle cell disease strategy. What are the key components of that? And are they integrated into the health system? The minister made the remark that that is such an important aspect of what needs to be done in attending to sickle cell.
Thank you for the question. You know, ultimately, we made the decision to do work in sickle cell disease because we were asked. Government leadership is critical to sustainability of response. But, you know, let's be honest, this certainly, and I'll tell you about the ask that brought us in from the Honorable Minister in Ghana, who wanted help in scaling up his sickle cell program. I'm sure this is not the first time that Chai was asked to help with sickle cell disease, but clearly we hadn't answered the call before. So why? You know, we want to support, well, I'll talk about our focus on inequities, but ultimately we act at the behest of governments, but we can only do so with the support of donors. And in the sickle cell area, the donors are few and far between. And so even now, our sickle cell strategy and our sickle cell program is fueled maybe 10% by donors and 90% by passion and anger at the inequity that we see. If we're honest about it, a number of our programs are probably already failing children and people living with sickle cell disease. We have malaria programs where we're screening children for malaria, never consider sickle cell disease. We're screening children at birth in many places for HIV, and yet what else are we not screening for? Among them, sickle cell disease. We go to a lot of effort to deliver services to patients in a non-integrated manner. Take samples from them, get them into a lab, and run a single test. So, you know, we can either look at the failure or we can turn it around into an opportunity. And I think I found inspirational the leadership of Ghana, what I've heard about the program in Uganda. And what I found remarkable is that by using health systems, lab systems that are already in place, maybe only need marginal additional investment, substantial progress can be made. I am awed by the program in Uganda, and in the donor mobilization session earlier, Honorable Minister was talking about thanking supporters for their contributions, and I was struck by the small numbers that were enabling a program that clearly is having a huge impact. I think, to me, screening and diagnosis is the key. You know, the numbers are remarkable. 300,000 children are born every year with sickle cell disease. The African continent is a continent of 1.4 billion people. So even with 300,000 babies every year being born, we talk about low prevalence. And what happens with low prevalence, it gets very expensive to find those children who do have the condition. then we find ourselves in a spiral. Lack of data leads to misunderstanding of the problem and underestimation, a lack of resource, and down we go. To me, screening and diagnosis are eyeglasses. They're the key to treatment. They're the key to data. Sickle cell disease is not evenly distributed. I mean, we just heard what probably is not a remarkable coincidence if one followed the data. So yes, there's a lot of work to be done on improving access to treatments, preventative therapies for patients. But I think it all has to start with screening. And I think we have to do it where patients are coming to us and where our health systems already exist in a more integrated manner.
Thank you very much. Dr. Neema, having heard all of that and knowing that WHO is the technical and coordinating entity on the continent, provides guidance to countries, provides guidance to public health institutes in partnership with Africa CDC, of course. When you reflect upon what you've just said, and especially from Dr. Rippon, what role can Afro play, what more of a role can Afro play in supporting especially high-burden countries to deal with sickle cell as we look forward?
Thank you. So I think one thing that we've said, there's the paucity of data and evidence, and so that's one area that we need to continue to work with countries to improve the availability of data, of their surveillance systems for sickle cell, inclusion into the IDSR system so that the evidence is there to be able to support policy. The awareness also is important from Selena, as she was saying, the awareness also for prevention, also premarital screening on those people who are at risk and all that. It needs to come into as part of programs of health promotion. So these are areas as we work with countries. So it's the Afro Regional Office, but they have country offices. We have that. Our role is really to support countries to adapt these. The other important issue is mainstreaming sickle cell disease management, integrating it into other existing services. So whether you talk of maternal newborn child health services, I know currently from WHO headquarters are working on revising the guidelines for children and young adolescents. And one of the key things for Africa was that we need to include sickle cell disease because it was not there. And some of the guidelines that were mentioned by the president here are now being used now to, feed into the development of that. Also HIV/AIDS. So one important thing is integration, but the other thing is also access. As she was saying, as Selena was saying, she was saying we're doing very well, we're at one clinic, and most of the times sickle cell disease services would be at specialized centers, and you can't reach everyone if it's at specialized centers. We need to have it down at the primary healthcare level and have a clear referral system where referral is needed. So WHO, as part of strengthening NCDs in PHC, which sickle cell is also part of that, is supporting countries in applying the PEN Plus packages, which also include sickle cell diseases. And then also, the Honorable Minister mentioned about centers of excellence. WHO is also developing a guidance framework for setting up centers of excellence for sickle cell diseases. So I think those are the key things. It's really ensuring that we get the services down there, but our role is really guidance, evidence, and also the advocacy and health promotion, and we'll work with countries to adapt those guidelines now when it comes to country level, depending on their systems and their specificities.
Thank you. Selena, another question for you. You mentioned almost in passing the minister in a little bit more detail. And right at the beginning of the video, Dr. Adama, you also mentioned that health is the complete state of physical, mental, and emotional well-being, and not just the absence of disease. and there's tremendous mental health impact of sickle cell disease. So perhaps you could elaborate a little bit more on how you are supporting management of prejudice and stigma of CHIRA, but also what you need as a family, or what you would have needed as a family for mental health and support of your own as you live with the disease.
I look at my introduction to sickle cell as one of those things that life never prepared me for. And then looking at sickle cell again, I always say it's an inverted triangle, because many children are born, but as we grow, we end up having very few who survive. So we need to change this inverted triangle to be a perfect triangle. That's the first thing. But then looking at what you're saying in terms of what a caregiver would have wished for, what any parent would wish for when they are told their child has sickle cell, is you need somewhere where you can fall back to. And falling back to it means that when diagnosis is done, it should be that immediately you're directed to a place where then you start care immediately. And when that care is started immediately, then you're hopeful that your child will live. You're hopeful that your life will be better than what you had anticipated. And this is one of the challenges that we face on a daily basis. And I could be one of the fortunate ones, but I interact every day with families that struggle on a day-to-day basis to just keep their kids alive. There's this young girl who right now she's in her 20s. I'm happy to say she's in her 20s. We started off with her when she was about 7 years old. Recently, when she used to come to clinic, she had finished school. One of the things that came out quite common was that every clinic time she had a crisis, a painful crisis. Painful crisis just means that she's in so much pain. And at first, the doctor and the emergency nurse did not take note of it. They were not taking it seriously. But then when it happened in a series of maybe 5 visits, they called me. And they said, we need to address a social issue here. And what is the issue? This girl, every time she comes for clinic, and I know her clinic is monthly, she's always in a crisis. And you know, when somebody's in pain, you can't go and start asking questions. But at that point, we thought it would be important we do that. So I asked, what medications are you on? And she lined up everything, including hydroxyurea. But if you're on hydroxyurea, your crisis should not be that frequent, you know. And when we kept on talking, she told me that one of the things that she doesn't take regularly is hydroxyurea because of lack of affordability and all those strains that they have to go through as a family. Her mother is a casual laborer. So on a day-to-day basis, she makes about between 200 shillings to 500 shillings a day.
That's $2 to $5.
Yes. And this is because she washes clothes for people. So there are days she doesn't get any work. And the days she doesn't get work, they have to either opt to go for food or other things, but leave the medicine. So as a clinic, we thought, how best can we create an intervention to this? And many a times we always reach out to well-wishers to help us buy medicine for patients. So at that point, we had some donation that had just come. And one of the things that we agreed is that for the next 3 months, we will be giving her hydroxyurea without fail and monitor if the pain persists. And the next month she came to clinic, she was pain-free. And the next time she was pain-free. And the next time she was not in pain. And she's a very interesting girl because when she walks into the clinic and she's feeling well, you'll notice her from the door. She will wear blue braids, really colorful outfits and looking really nice. And these are some of the things that we don't pick very easily because we live with these people. Had these doctors not noticed that, maybe they would have increased the dosage of hydroxyurea, which would have made it even more expensive for her, and the outcome would have even been worse than what we were experiencing. So that is just one of those cases which I say some of the things that caregivers have to go through on a day-to-day basis. There are many, many, many examples. There are many stories we have that sometimes break our hearts, where a parent walks in, the child is in pain, and the word she says is, let me say it in Kiswahili first, then I'll translate. Si akufe tu.
Oh.
So anybody who understands Kiswahili and knows what I've just said, let him just die. And the child is there. Now you cannot start scolding the mother. You first have to rescue everyone there, because it's not only the child who is in pain, the mother is also in pain. And sometimes we have to call them and tell them there are certain things you try and control yourself and not say in front of your child. But unfortunately, these kids listen to that every day. They're used to it. Your mother saying, if you died, you're better off. So there are many, many other things that people go through, and it breaks our heart also, those people who work with them, because I don't want to see a parent reject a child, and in the evening I tell her, take your child and go with them home. You get me? Thank you.
Thanks, Selena. I'm going to try and switch tack a little bit and come back to you, David, and think about the sort of the bigger picture. If we are to get every child who needs it on their medicine, if we're going to get hydroxyurea to everyone and get you to get the money to get hydroxyurea to everyone, demand has to be created. How do we go about creating that demand?
Yeah, thank you. So it's really hard to follow.
I know.
I mean, the first thing is to go back to my last point. We have to start diagnosing children, and we have to start diagnosing them early, and we have to do it in the health systems that we're already running, that are already interacting with those children. I'm just stepping back from your question for a moment. I've been told by people I work with that I draw comparisons to HIV programs too readily, but I'm really struck by a lot of the parallels here. The stigma, the perception of this being a death sentence when it really could be essentially a chronic condition. And I'll note that one of the most impactful approaches that we've encountered as CHI, and I think the HIV community has adopted, and we were perhaps a bit late to this, is putting patients first and working with advocates and patient advocacy groups. I think every single person who walks out of this room having heard what we've heard is going to add to the moral demand. But that doesn't translate into actual demand unless we actually implement in our programs, and it all starts with diagnosis. And when you diagnose, clearly we're creating advocates, and we're not just diagnosing patients. So all of that said, yes, if we have 300,000 children a year being born, most of them in a place, large place, but that we know, and we can start diagnosing them, the demand will be there. And as CHI, we've done a lot of work on enabling access and lowering prices. I'll tell you a secret. When the patients are there and the actual market demand is there, it's relatively easy to do. So, I think we have to sit with governments. Governments want to do this, assist them in developing their plans, assist them in beginning to implement those plans. And most importantly, we need to help find the resources for those to get to scale. And I think if we do that, the demand will be there. I'll put on a wonky hat. I used to be a chemist doing product commercialization. And when I first saw hydroxyurea, it's about as simple of a drug as they come. So the potential is there, but we just have to get to those economies of scale. And economies of scale is a relatively callous way of saying we have to find patients. We have to make sure that those patients are getting treatment.
Thank you. I know we're running a little bit behind time, so I'm going to take just one last comment from you, Lutz. And in making that comment, I'm just going to reflect on something you've said right now, David, which is we know 300,000 children are born every year. But the research seems to suggest that once we start screening, those numbers are going to be much, much, much larger. And so perhaps as a way of giving us our marching orders, Lutz, you could reflect on the elements of the SCD program at Novartis that could serve as a blueprint for the way forward in managing sickle cell disease as part of national health programs, as part of regional health programs, but also as part of global health.
Yeah, thank you. I think it's fair to say that historically the contribution of the private sector to global health has largely been through philanthropy or donations. And we started with that approach 20 or 30 years ago. Many others have, but then you wonder, you sort of load a certain amount of medicine into the driveway of the Ministry of Health, and you wonder why nothing happens and why no impact is being made with that medicine. And I think we have learned the hard way that we need to go beyond that. And I think that also the private sector has an obligation and a moral mandate to not just sort of produce and make medicines available, but also to consider where else along the continuum of care can we add value, how can we work with partners in order to do that. And I think particularly for a condition as complicated as sickle cell disease is, with different stages, with all different needs that have to be in place that have been discussed earlier, it's very clear that this is an area where we need to take a much more holistic view and a much more holistic approach and do that in partnership. I would say the other part that is important, and that's been said as well, is that we find ways to integrate our efforts into an existing health care system, and that we don't essentially create parallel structures, silos that just complicate matters and typically are not sustainable. As soon as the funding dries out, these systems collapse and you are back to the start. So I think the idea here of bringing the screening into other screenings that exist already, making sure that every interaction with a healthcare professional counts and delivers the maximum benefit is very important. The sustainability part, of course, also comes then through the local adoption. And I think it was very clear from the Honourable Minister of Uganda that there is a commitment to continue with this program. And the health system has brought a lot of resources into the mix in order to make this happen. Similarly, we heard earlier from Ghana, they have introduced hydroxyurea now into their reimbursement scheme, which is a huge step forward, so it doesn't depend on donor funding, but it's being locally procured and financed. Cross-sectorial collaboration, I think, came out very clear, and the more complicated a disease is, the more we need this. And then I would say last but not least, the need to innovate, continue innovating for neglected diseases, non-communicable as much as communicable diseases. We cannot stop. And I think it's fair to say that we see on the horizon interesting new developments to modify and to attenuate sickle cell disease. And of course, we wish them luck that they reach the light of the day and that they can make an impact on patient. We earlier mentioned very quickly gene therapy as the ultimate goal, and we believe all that is the ultimate goal, but we need to reimagine what gene therapy looks like. We will never be successful taking current gene therapy approaches that exist in the global north to sub-Saharan Africa. That's what gives me great hope, is our partnership that we have with the Bill and Melinda Gates Foundation to look at in vivo gene therapy, where essentially you would inject the gene therapy and everything would happen in the patient, essentially bypassing and avoiding the need for all this complex infrastructure. That is a moonshot, but we are certainly committed to, again, work with our partners in order to make this or bring this closer into the frame of reality.
I think the very strong case has been made here that we have a moral imperative to shoot for the moon. And so as we start to think about how we're going to do that, I would really like to invite you, Honorable Minister, Your Excellency, to please rejoin us on the stage so that we can have a discussion with the audience. And Dr. Adame, if you could also please join us on the stage. You will have seen them introduced in the film, but just as a reminder, Dr. Jane Ruth Acheng is the Honorable Minister of Health of the Government of the Republic of Uganda, and Dr. Isaac Adame is the Director of the Global Sickle Cell Network. We're going to take some questions from you on the floor now. I sort of see hands being raised. I'm being blinded a little bit by the light. There is one question already queued from Béatrice Garrett, CEO of the Fondation Pierre Fabre. If we can take your question. Thank you. Sure. Hold on, they're giving you a mic. Okay.
Thank you. So the Fondation Pierre Fabre, with a public utility foundation, has been invested into a sort of struggle against sickle cell disease for 15 years now in French-speaking Africa, in 9 countries. So we started with, supporting the Malian government for the creation of a reference center in Bamako, the CRLD. But now our approach has been more and more holistic. So we've been working into all the different aspects of the struggle against sickle cell disease, including outreach, newborn screening, especially in Burkina Faso, helping also government to implement a national policy, and also trying to integrate sickle cell disease within, the primary healthcare essential package. So I'm so thrilled that this coalition is taking place. Everything we heard, we can, bring our testimony that this is really the reality, and there is huge experience already on the continent. I can say in all the 9 countries where we're working, there are already is, successful experience. Now what we need is really to scale up in a sustainable way. My question to this audience would be what would be your recommendation to make sure that if we have bigger stakeholders now, bigger partners and organizations, how can we make sure that also the Francophone countries in Africa are going to have an equitable access to this new multilateral, what we wish, multinational fundings? Thank you.
Thank you. Perhaps David and Naima, I could let you take that question. Naima, I don't know if you can answer on behalf of the RD there, but yeah, sure.
I'll do my best, and I go back to diagnosis and the data. If you follow the data, even on the African continent, the prevalence for sickle cell disease is higher on the western side of the continent than it is on the eastern side. So, I think if you follow the data and the resources follow where the cases are, then they naturally would go there. Now, I know it's naive to say that donors just follow the data. There's a lot more to it. So I'm not sure I can answer in a more nuanced way than that. Maybe I'll turn to my fellow panelists to see if they have thoughts as well.
Thank you. I think just from the Afro side, the Francophone countries are part of the 47 member states that are under Afro. So when it comes to new guidelines, capacity building, we work across all countries. And many times, even when there's new guidelines, sometimes they would have an orientation session for Anglophone countries and an orientation session for Francophone countries, because they also have maybe similar characteristics and similar systems. So I just wanted to share that all countries are considered when it comes to supporting guidelines and new interventions and capacities. Thank you.
Thank you.
And we also have country offices in all those countries.
In all of those countries,
yes.
correct. I think I see and recognize from the film Marika Kazi, business director from Revity. You have a question too.
Hi, my name is Marika Kase, Business Director for Strategic Initiatives at Revity. So my special interests are really implementing and expanding newborn screening programs globally, and especially in the low and middle income countries. Revity has been previously known as a PerkinElmer. Today we have launched a new company name, Revity, and Revity continues to provide best-in-class newborn screening solutions, services and technologies that delivers full workflows for newborn screening laboratories around the world. So first of all, I think we've heard that newborn screening is really one of the most successful disease prevention systems. And a care for sickle cell disease really begins with newborn screening. But without early intervention, patient care pathway is incomplete. So today, with our partners, with our worldwide Sickle Cell Coalition, we are here united in impact, embracing impossible to improve lives of sickle cell disease patients in sub-Saharan Africa. And I think today I'd like to really encourage all of the ministries of health in low and middle income countries to consider setting up newborn screening programs for sickle cell disease and maybe implemented it alongside vaccination programs, HIV programs, or some other prevention programs. So at Revity, we are your partner delivering and developing solutions and technologies to really help to solve world's greatest health challenges, especially the burden of sickle cell disease. And I have a question to Honorable Dr. Jane Ruth Seng, Ministry of Health, Uganda. So economically, sickle cell disease contributes to high productivity losses and exposes families to great financial risks. So what would it take to gain government support to make newborn screening for sickle cell disease as a sustainable public health program in Uganda?
Can you hear me? Thank you very much for that question. And you have almost answered it. Countries want data. They want statistics. The ministries of finance want to know if they invest in that area, what will be the outcome? Will they stop death? Will the families be able to go back to work and become economically productive? So again, it takes us back to what you have just said, newborn screening, so that we know the burden, the actual burden on an annual basis, and how much investments can be put into it. Then you will be able to calculate the economic output that you can get from your investments. So newborn screening is the way to go. Thank you.
Thank you. I'll take one more question from the forum. Sorry, we're running out of time and have to close. And I'd like to give the floor to Dr. Alexis Thompson, Director of Hematology at Children's Hospital of Philadelphia, and also the representative of the American Society of Hematology.
And thank you so much for the invitation for the final question. This has been an extraordinary, albeit long session. So I will certainly keep my question brief. And thank you for certainly highlighting the American Society of Hematology. We've been very proud to be in partnership with 7 countries in sub-Saharan Africa to launch the Consortium for Newborn Screening in Africa. We've learned a great deal about not only the successes, but also the challenges that will come with scalability and sustainability, which is where we are now. There's not a question about feasibility at this point. We're quite optimistic that newborn screening can be done and that it will achieve the same goals that we have seen globally in the geographic north. My question really relates to the quality of life of patients, including their lifespan, and the question really relates to the efforts that we can think about putting in place that will actually ensure that we not only extend life, but we extend the quality of life for individuals with sickle cell disease. And I was wondering if among the things that we are thinking about, how we go about considering that as well.
Yeah. Who would like to take the question on quality of life? Dr. Dahmer, maybe? Yes, please.
Okay, we can share the question. But first of all, I'm a pediatrician. I have a family with adults and children with sickle cell anemia. And I know about the quality of life. But you're asking about the quality of life when they are on hydroxyurea. And I will just guide you to think about the quality of life that people with HIV live when they start on antiretroviral drugs. They blossom. They get better. You cannot tell who has HIV when they are on antiretroviral drugs. Similarly, with sickle cell anemia, if you start the treatment early, and again it is early, that is why it is extremely important to do the newborn screening and start them on treatment early. All those features of sickle cell anemia will not be there. The crises will not manifest. The children will blossom, and they will live for as long as it is possible. That is why we must take care of these children. If we can do it for those with HIV, what about these beautiful children that are gifts to us? We must do it. Thank you.
Thank you. Dr. Damayantada. Okay. Go ahead, please. I'd love to hear what you have to say.
I was just going to add that we know that we can reduce mortality, early mortality, but we want those who survive, who don't die, to live a good quality life. And that's why disease-modifying treatments have to be started early. And although we look into the promise of gene therapy and other innovative therapies, we need a foundation. We need to create a background of good quality care. So I see gene therapy as building a skyscraper. If you're building a skyscraper, you need a solid foundation for this skyscraper to be built. And that solid foundation is early detection, early disease-modifying therapy, giving them quality lives, knowing who the patients are. So when the promise of gene therapy comes around, you know the patients, you have a background of good quality care to maximize the impact of gene therapy.
Thank you. And thank you for having borne with us for a long, but I think you will agree, really interesting, really insightful and intense panel session. I would like to thank Dr. Rippon, Dr. Hageman, and you, Selina, very much for giving your personal perspective and real color to what it means to live with sickle cell disease. Dr. Nema Kimambo as well. Now, could I invite the 4 of you to please take your seats here at the front, and we'll cede the floor for the next session to Dr. Jane Ruth Acheng. And I think I'm to ask you to come with Dr. Odame over to the podium. Yeah. Yeah.
Thank you very much for staying through this session. We are now going to enter the phase of launching the World Coalition on Sickle Cell Disease. I know that the nomenclature has changed over time. At some point, we called it the Worldwide Sickle Cell Disease Coalition. Now, I want to announce officially that the final nomenclature for this coalition is World Coalition on Sickle Cell Disease. The coalition, simply put, is a unique multi-stakeholder, cross-sectoral partnership of entities that come from diverse backgrounds. National governments, international organizations like WHO and UNICEF, academic societies and medical organizations like American Society of Hematology, patient organization, public-private partnerships that have been launched, private entities, civil society, all of us coming together. But what we want to really emphasize is that each of these entities bring unique insights and capabilities to the table. So if you are here and you are interested in this coalition, all I want to say that you have a stake in this coalition. You have a part to play, and think about how you can contribute to elevating sickle cell disease, to enhancing coordination for global action. We know how to diagnose the disease. We know how to treat it. We know effective treatments for this disease. We know how to educate patients and their families. The challenge is that we can't do it to scale, and we can't do it in a sustainable way. So we remain at localized programs that reach only a small percentage of the population. How can we make diagnosis accessible to all? 43 million children are born in Africa every year. How can we test each one of them and detect the over 300,000 that have sickle cell disease? How can we ensure that hydroxyurea is accessible to all who needs it, and that they can be detected even at primary care level? So this coalition is to move us further beyond just pilot programs, beyond just demonstration programs, but to scalable national programs on a global scale. And we will only achieve that if we work together as a coalition, each partner, each member bringing their own capabilities and their access to the table. So there are three pillars that we are going to establish this coalition on. First of all, we want to engage country stakeholders to develop national sickle cell strategies. That includes advocacy and education as well. Second, we want to work with donor communities to mobilize the scale of resources to be able to implement sickle cell programs on a global scale that reaches every person in the country. And thirdly, we want to be a repository of best practices. So countries that are going to initiate programs know the best practices available. They don't have to find their own way to ensure that we provide care that is available to every individual, regardless of their geographic location. So together, we have to do this. We can't do it alone. And no one single entity has it all to deliver sickle cell care from the beginning of the journey of diagnosis till end of life. We can only do it as a coalition, and that is why the global coalition is needed, and that's why we are forming the World Sickle Cell Disease Coalition, and I invite you all to play a part in this coalition. In the next few months, we're going to come out with some details about how this coalition is going to be governed, how this coalition is going to operate. And by the end of the year, we want to establish a secretariat that is responsible to ensure that the plans of the coalition are well disseminated and every active member knows their role within their coalition, what their responsibilities are, and what they also expect the coalition to offer to them. We are not going to replace you, but what you're going to contribute is going to add up to others and realize the scale of operational direct programs for sickle cell disease that reaches every child, every adult who lives with sickle cell disease. So stay tuned. There'll be various announcements. Our website is now launched. If you haven't visited the website, it's www.worldscdcoalition.org. And it gives you a framework of what the coalition is about. You can actually enter in your details if you want to be a member and indicate your interest in being part of this coalition. It is for everyone, and I invite everyone in this room, whichever organization you represent, whether it's a national government or whether you're a private entity, you have a stake in what we are doing. Multi-sectorial, trans-sectorial, multi-stakeholder partnership. That's what this is about. Thank you.
Just a quick thanks to our guests who are joining us live and here in Geneva, those who are online, and our panelists, and of course our co-hosts, Novartis and the Ministry of Health of Uganda. Congratulations once again on the launch of the World Coalition on Sickle Cell Disease. I'm glad we got the nomenclature straight. There are QR codes around the room for you to scan and to learn more about how to get involved. We'd like to invite all the panelists and Coalition Steering Committee members up to the stage for a few photos and invite everyone else to stay for food, drinks, and conversation. And we are adjourned.